For my weekly rounds of my grand round presentation, I chose asthma. What is asthma? Asthma, also known as reactive airway disease, is a respiratory and lung condition. It is the narrowing and inflammation of the lower airway or bronchial tubes of the lungs that causes obstruction. Asthma is characterized by recurring episodes of spasmodic attacks, or commonly known as asthma attacks. During an asthma attack or exacerbation, these already inflamed smooth muscles become edematous and tighten, thus causing narrowing, making it difficult for airway to move into and out of the lungs, and ultimately making breathing extremely hard. Asthma typically begins during childhood, but diagnosing asthma in children is complex, particularly in children 5 years and younger. My case study is a 17-year-old male. He presents to the clinic with his grandmother feeling stopped up with dyspnea and nasal congestion, feeling tired, sore throat, productive cough with tan sputum, fever, and a yellowish nasal discharge. He reports he was at a youth function outside of at the lake over the weekend. His vital signs are blood pressure 126/75, heart rate's 95, respiratory rate's 28, temp is 101.8, and he's sat at 93% room air. There's bilateral wheezing heard on exploration. No retractions or accessory muscles used. No rales, bronchi, or rub. No drug allergies. There's a medical history of asthma, seasonal allergies, and mild scoliosis. Family history, his sister has asthma and allergies also. He is allergic to dust, mold, and grass. He denies smoking, but reports he has one parent in the home that smokes. He's currently active and on the swim team. He's on albuterol, Zyrtec, and Alka-Seltzer over the counter. He's later prescribed the albuterol inhaler, Zyrtec over the counter, amoxicillin Meteral dose pack singular, and he is to continue the Zyrtec. Incidence and prevalence. Asthma affects more than 25 million people in the U.S. It is more prevalent in female in the adult population and male in children. Most common cause of childhood illness in children is about 6.2 million people with asthma are 18 years and younger. It is estimated that 9.6% of children have asthma and about 7.7% of adults have this chronic condition. It accounts for about 3,500 deaths each year, and there is a higher mortality and morbidity among African American and Latino population. What causes asthma? There are several different possible causes that have been identified. While the exact mechanism of onset is unknown, it is thought to be caused from immunoglobulin E response to allergens. Most asthmatics are thought to be predisposed to the reaction according to their genetic makeup. Allergies are one of the strongest predisposing factor. In addition, frequent viral infections have also been associated with asthma exacerbation and emphasized as another possible cause of this condition. Acute asthma attacks are usually precipitated by triggers. These irritants include tobacco smoke, allergic reactions, dust mites, environmental pollutants, emotions, climate change, cold air, pollen, aspirin, insects, beta blockers, exercise or physical activity, stress, respiratory infection, and a history of GERD. Once exposed to a trigger, the bronchioles become inflamed, edematous, and cause obstruction and difficulty breathing. Hormones and emotions can also contribute to an asthma attack by a non-inflammatory mechanism. This correlates the increased prevalence in females than males in the adult population. All right, we move to risk factors. The environment, allergies, and a strong family history can increase the risk for developing asthma. The elderly are at increased risk for asthma exacerbation due to the aging process and decreased immunity. Significance. Asthma can be financially, socially, emotionally, and physically challenging. Frequent exacerbations can interfere with the activity of daily living and employment by missing days of work for doctor visits and acute episodes. It can also interfere with school physical activity and quality of life. It is estimated asthma costs more than $56 billion annually, including medical and drug expenses, work absentees, and sick days. About 14.4 million days of school are missed each year as well. Around 1/3 of asthmatics miss work due to exacerbations. And there has been a correlation between asthma and unemployment and disability. The high cost of drug and medical therapy increases the risk for noncompliance. Noncompliance to therapy can increase healthcare use and costs. Psychological disturbances such as depression and asthma and sleep disturbances were reported secondary to asthma. About 1/3 of asthmatics reported having depression or anxiety, and about half reported to have sleeping problems. As healthcare providers, it is essential to educate this population of patients on the causes of exacerbation and the importance of avoiding triggers. Also, it is important to address compliance to avoid further complications. In addition, engaging the patient to be an active participant in care is vital to effectively managing asthma and decrease exacerbations. While patients tend to not engage in activity due to fear of attacks, healthcare professionals should encourage exercise because it is proven to have short-term and long-term benefits for individuals for asthma. Pathophysiology. Asthma is the overreaction of the body's normal respiratory response to triggers, causing constriction, bronchospasms, mucus production, and edema. Once in contact with the trigger, a cascade of events begin to take place in the bronchioles. This causes the activation of inflammatory cells and mediators. Also, T helper cell 1 and 2 develop. T1 responds to microbes and activates the B cells into immunoglobulin IgM and IgG plasma cells. The T2 responds to allergens and helminths by stimulating B cells to produce IgE plasma cells. Thus, IgE then binds to mast cells, causing this production of histamine, prostaglandin Ds, granulocyte, macrophage, colony-stimulated factor, leukotrienes, cytokines, IL-1 to IL-5, tumor necrosis factor, and interferons. This all results to bronchoconstriction and inflammation of the pulmonary tissues. Cytokines such as tumor necrosis factor and interleukins 4 and 5 play a role in asthma. The THF is stored and released in the mast cells, and once activated, it increases airway inflammation. It also aids in the activation of eosinophils and neutrophils, resulting in airway remodeling. Additionally, mast cells can also be linked to exercise-induced asthma. Ultimately, this is a multi-cell pulmonary reaction to allergens. I just added this. This is something you can kind of look at. This is over here to the left. You can see the normal airway, and then to the right, you can see the asthma airway. In a healthy individual, the smooth muscles of the bronchioles right here are relaxed. In the asthmatic, the smooth muscles are inflamed. So it's kind of a visual. The clinical manifestations differ depending on the severity of asthma attack and vary from person to person. Attacks can progress from mild to severe without proper interventions. Exacerbation presents with mild to moderate wheezing on expiration and cough with or without mucus production. Also, patients have an increased respiratory rate dyspnea and often report chest tightness. As the attack progresses, the wheezing becomes more severe and can be heard on inspiration as well as expiration. The use of accessory muscles, distant breath sounds, shortness of breath, tachycardia, diaphoresis, and anxiety are other physical manifestations that can occur. Late signs and symptoms include hypoxemia, central cyanosis, ineffective cough, and diminished breath sounds. If interventions are not utilized or care is ineffective, asthma can progress to respiratory failure. Hence, prolonged attacks are serious and can lead to severe respiratory compromise or even death. Diagnosis of asthma is based on several factors, but is primarily determined by clinical manifestations. The family and medical history is assessed for predisposing genetic factors. Labs and pulmonary function tests can also be used to aid in the diagnosis. During the exacerbation, blood tests may reveal elevated eosinophils, increased IgE, hypoxemia, and hypocapnia. At first, ABGs will indicate respiratory alkalosis. One pulmonary function test that can be used is spirometry. Spirometry measures the obstruction and severity of asthma. Another test is the methacholine or histamine challenge test. This is established by inhalation of methacholine or histamines, which measure the airway responsiveness. Also, peak flow meter can help monitor the patient's asthma for improvement in decline. It will help evaluate the severity and degree of the disease. Usually with mild to moderate asthma, patients are instructed to use the meter daily to observe patient treatment effectiveness. Also, allergy testing can be used to determine triggers. Goal of treatment for asthma is to prevent and manage exacerbations using a multidisciplinary approach. Patient education is critical for the management of asthma, and prevention is aimed at identifying and avoiding triggers that can initiate an attack. Knowledge is a key factor to asthma control, therefore, an in-depth family and environmental history is needed to recognize contributing factors. In addition, pharmacological, non-pharmacological, and desensitization measures are part of the treatment plan. The pharmacological treatments for asthma is guided by a stepwise approach based on the severity and frequency of the exacerbation. There are two different types of medical classifications of treatment for asthma. It's quick release and long acting. The quick release medications are used for immediate assistance during an acute exacerbation. These are short-acting beta-adrenergic agonists and anticholinergic. They work by relaxing the smooth muscles of the bronchioles and generally providing relief in 30 minutes. His thought that administration of the short-acting beta-adrenergic agonists in combination to the anticholinergic can provide additional benefits in the treatment of asthma. Long-term therapies such as leukotriene inhibitors, immunomodulators, and anti-inflammatory medications are used for long-term treatment and are commonly prescribed in combination with other treatments. This is the medical management in the guideline to the stepwise approach for asthma. You can see here step 1, 2, and it shows you what to start with as far as medication and treatments go. This one didn't come up as well. The short-acting beta-adrenergic are administered by inhalation, which include albuterol, Xopenex, and Maxair. Anticholinergic medications like Atrovent are also administered by inhalation and work by blocking the vagal pathway, which produces bronchial dilation on the large airways. Long-acting therapies such as leukotriene inhibitors, modulators, and anti-inflammatory medications are used for long-term management. These include leukotriene modifiers and Singulair, Accolade, and Zyflo. These medications interfere with or block leukotriene synthesis and can be administered alone or in conjunction with inhaled corticosteroids, depending on the severity of asthma. Anti-inflammatory medications include inhaled and systemic corticosteroid therapy and are most effective. Inhaled corticosteroid are the initial treatment for improvement of symptoms, airway function, and decreased flow variability. To gain control and prevent recurrences for persistent asthma, systemic corticosteroids are commonly utilized. Long-acting beta-2 adrenergic agonists, theophylline and formoterol, and formoterol are potent bronchodilators along with anti-inflammatory medications. These long-term bronchodilators are used for symptoms that occur at night and prevention of exercise-induced asthma. Immunomodulators, Xolair, can be used for patients with allergies and severe asthma by preventing the binding of IgE to basophils and mast cell receptors. Anti-inflammatory therapy are typically used prophylactic and can include cromolyn and allocril. These drugs act by stabilizing mast cells for long-term treatment, but are contraindicated in an acute asthma attack. Alternative therapies. In addition, there are also non-pharmacological interventions that can be used with or without other treatment measures. For instance, breathing exercises or relaxation techniques can be used for hyperventilation triggers an asthma attack. Hyperventilation triggers an attack from panic or anxiety. For patients that react to allergens with severe persistent asthma, immunotherapy may be considered. Also, complementary and alternative therapies can be utilized alone or with other traditional treatments such as physical training, weight reduction, physiotherapy, proper nutrition, and acupuncture. Physical training is said to decrease the asthma symptoms and improve cardiopulmonary function. Weight management is important due to obesity being linked to airway hyperresponsiveness and asthma. Respiratory physiotherapy techniques can be used with other treatments and can improve shortness of breath and cough in an asthmatic. Proper nutrition with diet high in A, C, and D decrease the risk for developing asthma. In addition, acupuncture and Chinese herbal formulas are also used as another alternative treatment plan, but there is no evidence-based research to prove the effectiveness for asthma. Serious complications. Asthma is a long-term but manageable condition that requires ongoing treatment. If left untreated, it can be life-threatening and can lead to long-term effects and severe complications. Status asthmaticus is a severe persistent asthma attack that does not respond to treatment. The onset is rapid and can progress quickly to asphyxiation or respiratory arrest. Hypoxemia can occur from airway obstruction requiring oxygen therapy and ABG monitoring. Also, airway remodeling can occur due to frequent asthma attacks and consistent inflammation causing structural changes in the airways. In addition, dehydration is another complication that can occur as a result of diaphoresis and insensible losses from hyperventilation. Prognosis of asthma in adult onset is unclear. However, childhood onset asthma is relatively well known. Asthma symptoms that present in school age or in the first 3 years of life are transient. In fact, 3 out of 4 asthmatics will grow out of their asthma by adulthood. Remission is possible and is inversely related to the severity of asthma. Moreover, patients with childhood onset is approximately 3 times more likely to experience remission than that of the adult onset. In fact, asthma that develops in adulthood is 3 times more likely to suffer from persistent airway limitation and decreased lung function. Evidence-based nursing interventions and goals. Interventions and goals for asthma are aimed towards education and self-management, identifying and avoiding triggers, medication compliance, and improving lung function to enhance patients' outcomes and compliance. Education and self-management. The goal is to improve asthma control by providing significant information to support and facilitate self-management of asthma. Asthma is often not taken serious due to the commonality of the disease. For this reason, nursing staff should provide information and education to the patient and family in a way they can understand to increase their knowledge of the disease. Also, promoting and allowing patients to help form the action plan will allow the patient to control their own disease, therefore promoting self-management. Interventions should be focused on the patient's understanding of how important active participation in their care and outcomes. Providing patients with useful self-management tools such as the My Asthma app will offer additional support to improve patient compliance. Triggers, identifying triggers. The goal is to identify potential triggers and avoid exposure when possible to reduce exacerbations. The National Institute of Health advocates the control of environmental factors and reports that it's a significant factor in the management of asthma. According to one research, the Environmental Scoring System, or ESS, is a useful tool to help measure environmental home triggers that can be used with diverse population. The ESS data is collected with each home visit and can influence the improvement in asthma outcomes. Ultimately, identifying and avoiding triggers will help minimize and eliminate symptoms and possibly decrease the need for medication therapy. Action plans should be set in place with evidence-based research and a systemic approach in mind to promote compliance and management of symptoms. Medication adherence. The goal is to promote optimal medication therapy and compliance to maximize lung function and asthma control. According to the study, approximately 30 to 50% of asthmatics being treated with medication are non-compliant with the regimen. During the study, medication adherence was assessed by using the medication possession ratio for asthma medications, which yielded 8.3% of adherence. To increase compliance, questions should be promoted and answered concerning medication therapy. Also, cost can be an issue for patients and can lead to non-compliance. Assistant programs should be made readily available to the patient. Additionally, proper techniques of inhaled medication is important and should be demonstrated to promote effective treatment. Ultimately, the goal of asthma is to reduce respiratory impairment determined by decreased coughing, shortness of breath, use of short-acting beta-2 agonists, and sustaining a near normal pulmonary function. Also, another desired goal of treatment is to reduce the risk of complications associated with asthma, such as the advancement of disease process, exacerbation, and lung function loss. And here's my references.